Hi everybody, welcome to Pathophysiology 2. Let me introduce myself and my colleagues. I am Paige and you will also be hearing from Devani, Millicent and Danny. We are currently second year clinical technology students at TUT. Before we get started, let me break down how we will approach this video. Our talking points. Number 1, the introduction. Here we will introduce the purpose of our video. Number 2, a brief overview of the patient case report. Here we will provide you with a summary of the case and the patient's experience with the disease. Number 3, background information. I know, a little bit boring, but it is necessary. Here we will ensure you form a solid foundation to understand the patient case better. Finally, number 4, discussion and conclusion. Here we will compare the patient case with the available literature and draw a conclusion. Well, without further ado, let's jump right in. Introduction. The clinically diverse collection of illnesses known as muscular dystrophies all have the clinical trait of increasing muscle weakening. Muscle weakening is when your full effort doesn't produce a normal muscle contraction or movement. Duchenne muscular dystrophy, commonly referred to as DMD, is one of the most severe forms of muscular dystrophy. It mostly affects boys, while it can also impact girls in extremely rare circumstances. The girls are usually the carriers of the gene. DMD is a genetic disorder characterized by progressive muscle degeneration and weaknesses due to alterations to the protein called dystrophin. Around the age of 4, muscle weakness often starts and it becomes worse very quickly. In this presentation, we will discuss DMD affecting young twin boys in rural Kenya. Before we go any further, here is a visual representation of what a normal muscle looks like on the left and what a muscle infected with muscular dystrophy looks like on the right. Can you spot the difference? Now, a brief overview of the patient case report. Twin brothers from rural Kenya with no family history of DMD, both presented with delayed walking and frequent falling at 30 months of age. Initially, they were treated for vitamin D deficiency. The parents provided a detailed medical history where there was no indication of DMD in the current family line. At 3 years old, there was no improvement seen. Instead, the family reported that twin A had a speech delay. Twin A was referred to a pediatric neurologist who noticed extreme muscle weakness in the lower limbs. Under observation, it was noted that he was experiencing impaired breathing. Both twin A and B presented with depressed tendons, especially that of the Achilles tendon. Both twin A and B were sent for further testing. This included an MRI, muscular biopsy, and laboratory testing. Upon receiving the results, it was confirmed that both boys did indeed have DMD, and this was confirmed with the help of the biopsy, with the elevated creatine kinase CK levels in the blood and the muscle tissue. Both twins were treated with physiotherapy as well as glucocorticoids for active treatment against the DMD. Twin A's breathing, however, became more and more difficult. Upon further testing, it was determined that the DMD had progressed and was now affecting the heart muscle. This was resulting in cardiomyopathy. Twin A needed more aggressive treatment to account for this cardiomyopathy. Twin B responded well to the treatment, and there was no further degeneration of the lower extremities as to date. Now, let's move on to the background. I know this might not be the most exciting, but it is important. First up is epidemiology and etiology. The epidemiology. Duchenne muscular dystrophy, DMD, is one of the most common and severe forms of muscular dystrophy, predominantly affecting males with an estimated prevalence of 1 in 5,000 male births worldwide. Rarely it affects females. This disorder occurs across all ethnic groups and has been reported in various populations across the world. Here is a map that just shows some of the places where DMD has been reported across the globe. Etiology. Genetic mutation can cause a shortage of protein called dystrophin, which protects the muscles from damage and strengthens the muscle fibers. This mutation is inherited through X-linked recessive chromosomes. Males have an XY chromosome, while females have the XX chromosome. This makes males to be more prone to this disease because if their X chromosome has the mutation, they will present with the relative symptoms and indeed have the disease. In the female, if one X chromosome has the mutation, they won't have the disease, but they can pass the mutated gene to their children. I'd like to now pass the next section over to my fellow colleague, Devani.
Thank you, Paige. Let us continue with the background by looking at the pathogenesis of DMD. Pathogenesis. The pathogenesis of DMD is attributed to mutations in the dystrophin gene, which is located on the X chromosome. This then leads to the absence or reduction of dystrophin protein in muscles. Dystrophin protein plays an important role in maintaining the structural integrity of muscle fiber and protecting them from contraction-induced damage. In the absence of dystrophin, the muscle fiber become more susceptible to damage, triggering an inflammatory response. When we look at the inflammatory response is characterized by the infiltration of immune cells, such as macrophages and T cells, into the muscle tissue. The inflammatory response exacerbates muscle damage and leads to release of cytokines and chemokines that amplify the inflammatory response and contribute to the muscle degeneration. The loss of dystrophin leads to dystrophin-associated protein complex, which is referred to as DAPC, that contributes to the structural support of muscle fibers. This causes impaired calcium hemostasis, aiding the muscle degeneration and DMD. Now let us look at the possible clinical manifestations that a person with DMD can experience. They can experience manifestations like progressive weakness and muscle wasting, which is a decrease in muscle strength and size, loss of some reflexes, a waddling gait, frequent fall and clumsiness, especially when running, difficulty when getting up from sitting position or when climbing stairs, changes to overall posture, impaired breathing or respiratory problems, also lung weaknesses, cognitive impairment, cardiomyopathy, and to be honest, these things it sounds really stressful to someone who is experiencing these complications. Other common symptoms that can occur in Duchenne muscular dystrophy include calf muscle hypertrophy. This is an increase in muscle size like swelling, fatigue, where a person feels very weak, tall walking, short stature, which is height that is impaired, scoliosis, learning difficulties. Sometimes the belly sticks out due to weak stomach muscle. Knee may bend back to take the weight. I can't even begin to imagine how challenging DMD can be for the patient and their families with such difficult symptoms. Now let us look at the disease progression of DMD. It is split into 3 life stages, namely early childhood, which is 3 to 5 years, school age, which is 6 to 12 years, and finally teenage year and adulthood. DMD is a progressive disorder, meaning that the symptoms worsen over time. The disease progression can vary amongst individuals, but there are general patterns commonly observed. Here is an overview of the typical disease progression in DMD. The first one, early childhood, where there is a delay motor milestones such as walking and running. primarily the lower limbs are affected, so activities such as getting up from the floor can be difficult. Frequent falling is common during this stage. Being out of breath and respiratory issues and cardiac complication may start, but it is also rare in this stage. The second one, which is school age, muscle weaknesses continues to progress, affecting both the upper and lower limbs. Walking becomes more challenging and many individuals may be in wheelchair at this point. Lastly, is teenage years and adulthood, where a person relies on a wheelchair. Their daily activities are impacted by progressive muscle weaknesses, hindering the individual's independence. Breathing difficulties become more prominent and ventilators may become required. Cardiac complications advance and will require medication and monitoring. Disease progression can vary, where some patients may experience a slower or faster rate of decline. Life expectancy in DMD has improved with advancement in medical care. DMD used to have significantly low life expectancy, whereas now patients could live well into their 30s with a proper care and interventions. The picture below shows the progression of DMD from infancy to adulthood.
Thank you, Divani. So I am Millicent and I'm going to be continuing with the background of the diagnostic pathways. So Duchenne muscular dystrophy is a genetic disorder characterized by the progressive muscle degeneration and weakness. Diagnosis of DMD typically involves a combination of clinical assessment, laboratory tests, genetic analysis, and imaging studies. When a patient is diagnosed with Duchenne muscular dystrophy, clinical experience with all the necessary diagnostic tests are used in this process. So number one, we have clinical assessment, where a complete medical history and physical examination is required. A medical practitioner such as a neurologist or pediatrician will conduct a physical exam to assess muscle strength and function, look for signs of muscle weakness, and evaluate other symptoms such as delayed motor development, difficulty walking, and breathing problems. A thorough clinical assessment may include a detailed medical history. It is important to include any family history of DMD or any neuromuscular disease, neurological evaluation, and the assessment of muscle strength and function. At number two, we have muscular biopsy, which is a muscle biopsy which involves the removal of a small sample of muscle for examination under a microscope. The biopsy needs to demonstrate the absence or deficiency of dystrophin, which is a protein responsible for important muscle function that is lacking in individuals with DMD. This form of diagnosis is rarely needed to diagnose DMD, but it does help eliminate other possible muscle disorders and confirm the diagnosis of DMD. At number three, we have blood tests. So blood tests are done to check for elevated levels of creatine kinase, which is also known as CK, an enzyme that is released by damaged muscle cells. Elevated levels of CK can indicate muscle damage and can confirm DMD. At number four, we have imaging studies. Imaging studies include magnetic resonance imaging, which we know as MRI, or an ultrasound to evaluate muscle structure and function. These imaging studies are also used to monitor the progression of the disease. At number five, we have genetic testing and counseling. Genetic testing is used to confirm a diagnosis of DMD from a blood sample or cheek swab to look for mutations in the dystrophin gene, which is responsible for producing a protein essential for muscle function. Most cases of DMD are caused by mutations in the dystrophin gene, and genetic testing helps to identify the mutations. Genetic counseling is an important component of DMD diagnosis and management, particularly for individuals with a family history of the conditions. Genetic counselors can provide information about the inheritance patterns of DMD and options for genetic testing and family planning involving other members of the family, not just the patient. Diagnostic pathways for DMD involves a combination of clinical appropriate tests. Accurate diagnosis is important for appropriate management and treatment of DMD. And here we have a visual representation of the diagnostic pathways that we have just discussed. So now let's move on to the treatment. So despite significant therapy progress over the past 30 years, DMD is incurable. However, a multimodal medical, surgical, and rehabilitation strategy focusing on the DMD symptoms can change the disease's course naturally, enhancing quality of life and lifespan. Method of treatment must consider the patient's unique needs based on the disease stage, take into account sophisticated medical planning and the shift from pediatric to adult treatment, and include more general elements of well-being and quality of life. So first on the treatment list, we have respiratory care. So the average lifespan of those with DMD has significantly risen because of better respiratory treatment. According to recommendations for respiratory treatment, lung function should be evaluated every year following diagnosis and every 6 months following loss of mobility. At number 2, we have cardiac care, where early identification of the signs of insufficiency and arrhythmias by examination at diagnosis and every year after that is part of management of the cardiac manifestations of DMD. Physical examinations, electrocardiograms, and if available, cardiac MRI should all be part of this evaluation. Angiotensin converting enzymes, also known as ACE inhibitors and beta blockers, are used to treat symptoms and signs of heart inefficiency and abnormalities. At number 3, we have orthopedic management, where the overall aim of orthopedic management is to optimize or preserve the weakened muscle function and to prevent severe deformities such as contractures or scoliosis. So at number 4, we have endocrinological management, which should address impaired growth, bone health, glucose, fat metabolism, and delayed puberty, all of which are compromised in patients with DMD and are further affected by glucocorticosteroids. At number 5, we have neurodevelopmental and neuropsychological management. So specific attention should be paid to the management of neurodevelopmental and neuropsychological disorders in patients with DMD. A referral for neuropsychological evaluation should be considered at diagnosis of DMD, and educational support may be required. Lastly, we have glucocorticosteroid treatment. So the strongest recommendation is the use of glucocorticosteroids, prednisone or deflazacort, in boys with DMD when their motor development stops or starts to decline, and to continue treatment throughout life. The age of initiating steroids varies between patients but should be as early as possible. So some of the treatment mentions above are dependent on whether the patient's DMD worsens. So that is the last of the treatment, and now I'm going to hand over to my colleague Danny.
Thank you, Millicent. Now let's go through the discussion. Here we will discuss the investigation and diagnosis of the patient. Both twin A and B underwent physical examinations by the pediatrician, where it was noticed that the patients presented with delayed motor development, frequent falling, and had difficulty walking. At first, both boys were treated with vitamin D deficiencies with vitamin D3 tablets. Once both boys worsened by age 3, experiencing labored breaths, continued falling, and difficulties walking, their medical history was re-evaluated. There was still no link to DMD in their family history. The pediatric neurologist then requested the twins to have MRIs and laboratory testing done aligning with the diagnostic pathways for DMD. The laboratory testing presented elevated CK levels and a biopsy was performed to confirm the diagnosis of DMD. The patients, as well as the family, were advised to see a genetic counselor to understand the next steps. They were able to obtain the necessary information regarding genetic inheritance and how other family members can determine their genetic standing regarding DMD. The twins' diagnosis did not stem from expected origin, this being inheritance, as according to medical history, there was no DMD recorded in the family. Mutations in the encoding gene is caused by structural defect of sarcolemma protein, which resulted in DMD. In this case report, the patient's family history did not show DMD. The twins had DMD as a result of defect genes. In this case report, identical twin boys were diagnosed with DMD at an early age of 3, presenting with progressive signs earlier than expected, such as respiratory issues and cardiac manifestations, which are only expected at an older age according to research. Diagnosis of DMD at 30 months was not made. However, DMD was present earlier than when they were misdiagnosed with a vitamin D shortage. Now let's look on the follow-up and outcome of the patients. Upon follow-up with the twins, it was noted that both twin A and B were going for physiotherapy and were being treated with glucocorticosteroid medications, namely prednisone, which is also known as glucocorticoids, to delay the loss of ambulation. They were both regularly sent for respiratory testing to check lung function as suggested by literature. Twin B was responding exceptionally well to the treatment, thus the degeneration of muscles due to DMD was being slowed successfully. Twin A, on the other hand, developed cardiac complications leading to cardiomyopathy and is being treated with angiotensin-converting enzymes, inhibitors, and beta-blocker medications. This is helping Twin A improve his respiratory issues as well. Cardiac issues are common among DMD patients. Twin A's speech delay persists but is seeking help from a speech therapist to help aid him along. Cognitive challenges such as communication via speech is common with patients diagnosed with DMD. Twin A and B respectively experience more struggles going forward and might need to seek out a speech or occupational therapist. Twin A and B received treatment via methods that are supported by literature. However, the boys are still very young and their reaction to these treatments could change in the future. They will have to be closely monitored. Now let's look at the conclusion. As already mentioned, Duchenne muscular dystrophy is a genetic disorder that causes progressive muscle weakness, leading to a significant disability and premature death. In the case discussed above, the twin boys were unlikely candidates for DMD due to being so young and especially because the DMD had progressed so quickly that there was no family history of DMD. Diagnosis was prompt after it was decided by the pediatric neurologist that they ran diagnostic tests aligned with diagnosing DMD on the twins. The twins had a faster rate in progression of DMD than what is expected at their age, but luckily their pediatric doctor considered DMD as a reason for the symptoms they were experiencing. Although alternative treatments have been attempted, not enough research has been done to determine how effective they are when compared to daily dosing. Although there is a lack of evidence to support early use, an increasing number of studies indicate that therapy before the age of 5 is particularly beneficial when there is a history of DMD in the family. The most successful course of treatment for patients has been discovered to be corticosteroid therapy overall. In independent long-term clinical studies, patients given the corticosteroids, prednisone or deflazacort showed improved muscular strength, prolonged ambulation, and better respiratory function. Although the disease progression is only temporarily slowed, these benefits can be short-lived, and the medication can have a number of undesirable side effects. In this fatal and progressive muscle dystrophy, early counseling and genetic tests like multiplex ligation-dependent probe amplifying are being used to extend and enhance the patient's life. With better care and longer life expectancies, people with Duchenne muscular dystrophy and their families face new difficulties and demands on the support system. This patient population needs thorough and close monitoring, including during the transition from childhood to adulthood.
Thank you, Danny. Now, before we close off, let's look at the opportunities for further research. While there is no cure for DMD,
There are ongoing efforts to develop new treatments and therapies that can improve outcomes for affected individuals. Here are some potential areas for further research. Number 1. Gene therapy. One promising approach to treat DMD is gene therapy, which involves introducing a functional copy of the dystrophin gene, which is mutated in the DMD, into the muscle cells. There have been some promising results in preclinical studies and early-stage clinical trials, but more research is needed to determine the safety and efficiency of gene therapy in DMD patients. Number 2. Stem cell therapy. Another potential approach is stem cell therapy, which involves using stem cells to regenerate damaged muscle cells, such as mesenchymal cells, to produce pluripotent stem cells. But more research is required to determine the optimal type and dosage of the stem cells to use, as well as the best way to administer them to the affected muscles. Well, we have now reached the end of our video. I hope that you have now learned more about Duchenne muscular dystrophy. I'd like to thank my colleagues again for doing this video with me. Below you will see the references used in this video, and you can go and look them up yourself to learn more about Duchenne muscular dystrophy. Thank you.